Well, hello again, Jay here. Okay, time to give you an update on what's happening, what treatments I've had, or what tests I've had, the results of at least one of those tests, and some of the science of this that I find interesting, and you will find interesting, especially if you're going through this sort of thing yourself, and what it's like to be in the in those areas getting these things done. So let's first talk about the thing that friends and family will be waiting for most, and that is the results of a PET scan. I got a PET scan done a couple of days ago on the 6th, and for that they scanned my entire, actually everything from the knees through the top of the head. And I'm going to read from my writings a little bit about that because, well, it's what I wanted to document as I went through this process so that everybody else would have a better idea of what to expect. So on the 6th day of this month, I went in for my PET scan, which is a positron emission tomography. Got an intravenous feed of a radioactive substance called fluorox-glucose, aka FDG. It is a form of glucose. This is kind of interesting. They injected it into my arm and bloodstream, and it behaves a lot like sugar. Active cells, which include cancer cells, so they're defining them as active cells, absorb more of it because active cells use more energy. After they gave me the needle, there was a period of about 30 minutes where I rested in a chair. I was told not to use my phone, not to do anything but to just sit there for the whole 30 minutes. I've since found out that people use their phone all the time while they're waiting for this stuff to propagate through the body, and that was kind of an overkill statement. But that said, I just sat there, did what I was told, and this FDG then propagates throughout my body. Organs and tissues absorb the FDG tracer material. The expectation is that areas with higher activity, including tumors, collect more of that tracer material, which is the glucose-based whatever that they uptake, and will stand out more obviously than other cells. These particles of tracer are referred to as positrons, which is the nuclear reactive aspect of this, and as the name implies, it's the positron emission tomography. A computer converts the detected signals into detailed images. Bright hotspots mean high activity, which is possibly cancer, infection, or inflammation. And let me explain that. So high activity cells aren't just cancer. I could have an infected tooth. I could have inflammation for some other area, that my body's responding to for some other reason, and they're going to uptake this stuff too, and those would fall into the category of false positives. But doctors who know what they're doing, they know what they're looking for, they know the area they're concentrating on, enough of it makes sense that they can read between the lines, if you will. Dark areas means normal or less active tissues, and yes, doctors analyze the results one slice at a time, looking for abnormal patterns, because a PET scan literally does that. It's one slice of your body over all the way down, and it's like you're slicing a ham, and putting them together, you can slide back and forth and see, look at the body progressively and look for those abnormalities. And it says, in layperson terms, think of a PET scan like a heat map of your body's activity. The heat shows where cells are working overtime. And I've used AI along with my own interpretations to break this down for the layperson. FDG uptake isn't exclusive to cancer. Anything metabolically active will light up. Inflammation, infection, healing tissue, brown fat, I guess I've got some of that. I usually see that on the inside of fish skin. And normally active organs like the brain, heart, kidneys, and bladder. So these are active organs that doctors will know when they look at it that those are lit up all the time anyway. You can ignore that or whatever it may be. So that's why radiologists look at the pattern, location, and intensity, often reported as SUV or standardized uptake value, rather than just a bright spot equals cancer. Of note, some cancers, this is important, some cancers are less FDG avid than others, so a quiet PET scan doesn't always rule things out. And certain thyroid cancers in particular can be variable in how much FDG they take up. Now, part of what I've got going on is the thyroid, and so this doesn't, this may not be conclusive based on what I'm just reading. So let's talk a little bit about that experience of getting a PET scan. The day before, I couldn't have anything with sugar in it. That's important. No sugar, because you'd have too much sugar in the body, and then those cells would not have been responsive to the sugar intake, so glucose intake. So 0 sugar the day before, 0 caffeine the day before, 0 alcohol, of course, and protein, no problem. I have as much protein as I wanted to, eggs, steak, chicken, whatever. So there was a little bit of a diet thing the day before. It's interesting about that whole sugar thing, that it reinforces the idea that cancer cannot live in an environment that has no glucose to uptake. So the less of that you have, it seems like the better off you are, period. All right, I found it. Skagit Valley Hospital Regional Cancer Care Center. Getting ready to go into the big donut. I took this picture inside the lobby, and this is the actual donut I was in. I took that picture also. They had me sit in a chair for a half hour. While waiting in the chair, they inject you with this fluid that they call FDG. That was kind of interesting. It has some kind of a metal container around it, which presumably was the radioactive stuff, and alongside the normal intravenous material. I think two things went in together while that stuff was uptaken. I got to know the fellow that was actually doing this. I think it's important that I take the time to get to know my caregivers a little bit. You know, how long have you worked here? That's an easy question to ask. And you know, next thing you know, they're talking about retirement, they're talking about children, they're talking about things that matter, and we become relatable, and it makes it a better experience, and perhaps on some level more likely that your care will be a little bit better received as a result. So I get on a long bed that slides into a big white donut, and you can't read, you can't move, you can't wear anything metal at all, anything that's magnetic you can't have on you. So forget about earplugs and phones and all that kind of stuff, your belt buckle, your keys, everything comes out or off. I dropped my pants to my knees. I wore pajama bottoms, my pajamas underneath that, because I thought I was going to be taking my, he said, no, just pull them down to your knees. That process of going in the donut took probably about 20 minutes, and they move you in, you know, and they move you back, and they move you in some more, and you just kind of waited out 20, 25 minutes later. I got off it, and it was done. But in any case, that was the process. Painless, a little time consuming, waited it out. Now let's move beyond the PET scan. Oh, wait a second. You want the results of the PET scan. That's the important part. The results of the PET scan, you are looking at the results of the PET scan. I'm not going to make you read all this. I'll just go down a little bit and then summarize it. So it indicates the reason for the PET scan, the technique of the PET scan, and you can see specifically they talk about FDG here. Let's see, findings. Lymph nodes, multiple. So there is more than one lymph node that has evidently got cancer in it. And I thought up till now it was only one. So that's new information. Brain is unremarkable. I take that personally. MRI is more sensitive for detection of brain lesions, so that may be an MRI in my future, I'm not sure. Next space is poorly defined, avid right tonsil lesion on image. So they do see something about the right tonsil, which is obvious. That's where the cancer started. It may be poorly defined, but that's definitely where it started. But it does see it, and it has a maximum of 7.5 millimeters, I'm guessing. That corresponds to the patient's known tonsil. Vessels unremarkable, salivary and thyroid glands. Here we show FDG avid left thyroid mass on image 106 has an SUV maximum of 3.5. So there is some kind of an uptake there, it looks like, but it talks about this SUV, which was, if we remembered earlier, it was like, well, does that matter or doesn't that matter, all things considered? But we'll talk about that later. They did a fine needle aspiration to further diagnose that thyroid, which we'll talk about. Thorax, in the thorax area, no enlarged lymph nodes, no abnormal tracer uptake. Chest wall, hallelujah, no abnormal uptake. That is my lungs. That's all this kind of stuff. Oh, and here it comes specifically. Lungs and pleura. No pulmonary nodule infiltrate or consolidation. No pleural effusion, which I guess is probably the word no is good to me. The rest of it, somebody else can figure out. Heart and vessels, heart size is normal. I like that. Coronary artery calcifications are noted. So I don't know to what degree that is. That's obviously going to be interesting to me. The aorta and pulmonary arteries demonstrate normal size. Calcifications are noted in the thoracic arc, wherever that is. And aberrant right subclavian and artery passing posterior to the esophagus and originating from the thoracic arc, a normal variant. Okay. Esophagus, small incidental hiatal hernia. Okay. A lot of things going on inside that you just don't know about. Abdomen and pelvis, nothing to write about there. They say liver, everything is unremarkable. Again, I'll take that personal, but be grateful for it. Bowel, normal caliber without significant wall thickening. Colon diverticulosis is noted without inflammatory changes concerning for acute diverticulitis, so that could be something. Minor, they're obviously not concerned about. Appendix is normal. Peritoneum, which I think is some kind of outer covering of something, but I don't know what that is. Vessels, aorta, inferior, normal size. Mild atheromatics plaques are noted in the abdominal aorta. So a little bit of a plaque thing. They haven't raised an alarm, but it's something that I certainly am paying attention to. Pelvic organs, mild seminal vesicle and prostate gland enlargement, coarse prostate calcifications. Amazing that they can see stuff on that level. A heterogeneous FDG uptake in the prostate gland without a focal point lesion. So, really interesting to go over all this, and I'll certainly be digging into what that means exactly. Bladder unremarkable, and if you're a doctor and you see this and you want to weigh in on some of that, love to hear from you in the comments. Bones and extremities, no uptake. Hallelujah to that one. Lungs, bones, those are wonderful things. Impression, FDG avid tonsil lesion consistent with the provided history that they already know about. Multiple right level, this side, 2 FDG avid lymph nodes consistent with the lymphadenopathy. No concerning contralateral FDG, which I'm guessing they're talking about the other side, lymph nodes identified. No additional lesions concerning for distant metastasis. Forgive me, I don't use these words every day. And so that appears to be saying that there's nothing further on beyond this area that's been revealed, which is obviously good news. Mildly left avid, mildly FDG, okay, avid large thyroid mass, so there's some FDG uptake in that thyroid mass, but it's mild, and they recommend a percutaneous biopsy. Well, I can tell you from my own recent experience, that means getting a needle in the throat, which we'll talk about. This is likely unrelated to the previous squamous cell carcinoma. Both benign and malignant thyroid nodules are on the differential, whatever that means. But bottom line is they don't think whatever's going on in the thyroid is related to whatever's going on in the tonsil. Don't know how that can be, but that's their take. Okay, so that is it for the PET scan. It's done. It's behind me. The tests are done. I've got no treatment yet, remember, but we're getting all the knowledge that we need, so the appointment with the Fred Hutch Center in UW Medicine, they'll be able to plot a course for me. Now let's talk a little bit about the thyroid FNA. So a thyroid FNA, which stands for fine needle aspiration. It shows a video here, which I think I'll show you. So that's what this looks like. Okay, so there was an example of what that process is like. I don't know if you can see it, but there is some of the aftermath of what goes on there. Okay, so now let's talk about the experience of getting an FNA if you have to get one of those done. I'm going to talk about my experience. Yours will be somewhat similar. Bri was the woman who first checked me into the digital imaging department of Island Hospital here in Anacortes, Washington. It is more pleasant for them and for me if we get to know each other a little bit, if they are open to it. I feel it makes them, it makes it more likely they will care about me, and conversely, it makes me feel at ease in having what you might call a micro relationship with my caregivers. You know, it's people in general. I'm a people person. It's easy for me to open up, ask them a little bit about themselves, let them know a little bit about me. And I just think that, you know, other than normally we're silent, we say nothing, we go through the process, they do what they do, we say goodbye, and that's it. I just feel like this adds another dimension to it. It turns out that Bri lives in the same town I do, and we frequent some of the same spots in the neighboring town of La Conner. She had me lay on a massage table and put a pillow under my neck to tilt my head back a little bit and expose the area that they were going to be working on. She then applied ultrasound gel and got an ultrasound image on the screen, and I could see a little of that image out of the corner of my eye because the display was right near where I was laying. She isolated the thyroid area with the ultrasound so the radiologist would have a good view of things when he came in. Our radiologist PA, named Jeff Schofel, I think it is, then came in to perform the FNA. Very likable guy. He told me right up front this would be very routine. They would numb the area. They'd use 6 different needles to get enough material. Now I don't know if he used 6 different, literally different needles, or the same needle 6 times. I was getting poked so much, I felt like a pincushion, and I couldn't see. I was like that, whether he was using the same needle multiple times or different needles. He did inform me that he uses a larger millimeter needle to ensure he is getting more tissue instead of just cells. So there's a higher likelihood of not having to do this a second time. And I've read that, I've heard that this particular diagnostic measure doesn't always get the material it needs, and sometimes they have to go do it again. And it's a tricky thing, the thyroid, and getting something that's worth a darn out of it. And this is unfortunately where we're at these days with thyroid cancer. And so anyway, he had the bigger needle. He took out more material. I certainly could feel it, although they did numb it with something called lidocaine on the outside. I got a needle. And so it really wasn't bad, other than knowing somebody's getting a needle. You can feel it in there, but it's not bad at all. And then in talking to Jeff, I learned he's a fisherman, has 3 daughters, including an unplanned young one that will likely delay his retirement. Good conversation, nice guy, did a fantastic job. Bri did a fantastic job, and I'm grateful for them both. I told them both before I left that jlepore.com would lead them to my ongoing YouTube channel about this whole process, and so that they might find themselves talked a little bit about theirs. So I'm not sure if they'll look or not, but if you do, please leave a comment at the bottom of the video and say hello. Okay, so that's the only thing we're waiting on right now are the results of the thyroid FNA, fine needle aspiration. Why they call it aspiration, I don't know. You know, if I aspire to do something, it's like a goal in life. But evidently, in medical terms, it's got something to do with the vacuuming process of pulling stuff out of something. So all that's behind me, and all these tests are ready. So when I show up at Fred Hutch in Seattle, they can plot a course. Now let's take you down a slightly different road here. I'm interested in the science. I'm interested in the digital imaging. You know, you just took a freaking scan of my Jay's head, neck, whatever. It's my body. I want to see what's inside. For some reason, the medical establishment seems to be resistant to that on the surface. I don't know what that is. But in the case of Island Hospital's digital imaging department, I requested it either 2 or 3 times. I can't remember. But when I went there to get my fine needle aspiration, they handed me this with a CD of the digital images that I was requesting. And that may be normal. They're busy. They did a great job. But in my research using AI indicated that the digital imaging would probably be accessible to me if I went down that road. Normally you would never know about that. Now I do, and I'm very interested. So let's just look at some of that digital imaging. And by the way, isn't this a classic picture? I mean, who has a picture of themselves that look like that? That was pretty cool. Okay, so let's start with, I'm not going to cover all of these images. I am going to show you a little of the science behind it. We're going to take a look at this left one here. That is the top of my head. Now, I'm going to move the mouse 1 click at a time, and you will see it's coming down my head and giving you a view of everything inside. And that is Jay's head. And there are my eyeball sockets showing up at the top there. So that's the direction I'm facing. You can see my nose. Now, there are 350 or so images in all of this, and I'm not going to walk you through them all. And it gets eventually done into the chest cavity, right? And I see these things on the side over here. They could very well be the lymph nodes. And I'm not entirely sure, but I think that's what I'm looking at. Or that could be the thyroid mass, but I think it's the lymph nodes. Okay, you get a good shot of my teeth right there. Okay, so let's talk about what happened next. And by the way, this over here is my thyroid ultrasound. So that was, the ultrasound is a very different imaging than the, this is what you see when you're looking at a baby and, and that kind of thing. I don't know how anybody makes anything out of this, but they do. They know what they're looking at. I don't know what I'm looking at, so I would have a much harder time with understanding the anatomy. So what I did, being a computer guy, is I opened the CD. Let's see if I've got it here. Yeah, I opened the CD and I looked for the images that related to what I was seeing in that software. And I found the images. Here, if we look at the large thumbnails, we see the 350 or so images that software is progressing forward and backward, and all that's great. So now I wanted to see, could I drop those images into AI and have them analyze it and see what they come up with? Let's make them the doctor for a moment. And so I opened up Claude and I said the following: I would like you to put yourself in the role of, and with the expertise of, an oncologist. I have 345 JPEG images averaging around 85 kilobytes in size each that are the results of my recent CT scan of the neck area. The goal was to see if anything resembling cancer or other unexpected abnormalities revealed themselves through these images. Are you able to accept those images and interpret your findings to me? To which Claude said, I appreciate you trusting me, but I want to be straight with you about what I can and can't do here. I can't interpret your CT scan images, and I shouldn't try. Even setting aside, So bottom line is, it talks about what a CT scan is, it talks about what it can do, what it can't do, and that's the end of that communication, that consultation with Claude. And I've told people before, what you have today, each AI agent is seats around the table. You can't put all your eggs in one basket. So this is what Claude said. I could have just, taken my ball and went home and forgot about the whole thing. But why would I? When I can call ChatGPT in, or Gemini in, or Grok in, or Manus in, and I can all ask them for their opinions. Well, I didn't really want to go through all that time, but I certainly wanted to kick the ball further downfield. So I opened up ChatGPT and I simply copied and pasted the very same question. Nothing changed. And it says, yes, you can upload the CT scan JPEG images and I will help review them for visible abnormalities and explain what I see in plain language. And it talks about all the things that it can do. And it says, I'm not a licensed radiologist or oncologist. I cannot provide a definitive, you get the disclaimers there, I understand. And then it talks about what it can do. So I then took those images and I put them in zip files. There's something called DICOM images and the images themselves, which it asked me for the DICOM images and I was able to find them. I then upload them, and the DICOM images are the images that software uses to write whatever it writes on top of the images, or it's more descriptive. It's something that the doctors presumably interpret and understand those images better as a direct result. I've opened one of those images, and I'm not going to bore you with all the details. One of those DICOM files, but I'm not going to bore you with all the details. So here I am attaching the DICOM files and associated images. These are known as study, and I provided the number associated with the study, which I pulled off the disk. There are several hundred slices. A careful review will take some time. I'll work through the study systematically rather than making quick assumptions, to which my reply was, that makes sense. Take your time, think carefully. A careful review on a granular level is always more important than speed. It ensures the most accurate interpretations of the data. Now, why am I taking the time to tell you what I just told them? Because you're setting the stage. If you tell them to go fast, they'll go fast. If you tell them to take your time, go granularly, think carefully, they will take longer and be more careful, especially things like think carefully. They'll take the time to do things in a way they wouldn't do otherwise because they are your instructions. Okay, so ChatGPT finished doing what ChatGPT needed to do. And explained the scan does not scream metastatic, yeah, that's right, neck cancer, which would presumably be something spreading, but the left thyroid nodule is significant, should not be ignored. And so I asked it, well, that's great to give me a few words in a one sentence conclusion, but what the hell is that? Can you generate or show me a picture or the picture that has the dominant complex module mass in the left thyroid lobe, and draw an arrow to the area of concern? So ChatGPT provided me that description in its reply, and so now I'm trying to isolate what it saw. And so it sends me this picture with an arrow that's not really even an arrow. See if I can blow that up a little bit. No, I can't. It looks like a flag, and it's not pointing to anywhere. I let it know that this arrow points at nothing. It does not even look like an arrow. I'm trying to have you make obvious to me the area of concern, at which point it created this wonderful image, and it very clearly draws a circle around the area of concern, a clear arrow. How it gets it so good the second time after screwing it up the first time so badly, I don't know, but that's what happens. And so you got to keep asking the question. You don't just walk away from that image saying, oh, well, they don't know what they're doing. You've got to frame it a little bit differently and present it once again. So then I replied, what's this black area to the side of this mass that you're describing? Is that a thyroid? I don't know what the hell that is. I'm a lay person. And so I put an arrow in there. I'm using my own graphic software. I pasted it back, and then it describes that black oval as being the internal jugular vein. I thought, well, that's kind of weird. It looks like this mass, which is supposed to be a thyroid mass, is pressing on my jugular vein. It seemed a little off to me. And so I told it, interesting, it seems I should be seeing two thyroid lobes in that picture. I do not see the right thyroid lobe. Can you also draw an arrow to it, if it is possible, in this picture? Well, then it gives me a new picture. And this picture shows the right thyroid, that it's created a circle in green, versus my left thyroid, which is obviously much larger. And that, I see about more symmetry there, because that would be the center right there. And we've got our left and our right, depending on how you're looking at things. And it points out that that black hole that it previously called a jugular vein, it is now describing as a trachea. Well, I still don't know if it knows what it's talking about. It looks all rather small for a trachea, but hell, I don't know. I'm not going to take it any further than that. And now it says the internal jugular vein is this big mass over here. That is presumably my backbone. These symmetrical areas on either side, I'm not entirely sure. If you're a doctor and you see this and you can weigh in on what's going on there, I'd love to hear from you. Okay, I then move forward and upload the images associated with the ultrasound. You know, that was the CAT scan. I also got an ultrasound done of this area, and I want to see what they pick from that. Won't go into as much detail here. I uploaded all the images and the DICOM files related to the ultrasound. I gave it exactly the same instructions. It's a new data set. I don't want it to skip anything. Take your time, granular level, all that kind of stuff. And then main finding, CT scan corresponds with a large dominant left thyroid nodule measured on the ultrasound, and it gives centimeters, not millimeters. And cancer concern does not look obviously like aggressive thyroid cancer. However, unknown unknowns, and they go back to saying a fine needle aspiration biopsy would be the logical next step, which is what I'm getting done. So that's pretty much it. I do want to just touch one more time, as I've done in the past, on the importance of a medical diary. You need to be putting the date, the event that's current, planned, and filling things in as planned turns into current. And so you have something like this. You can see it started on 4/17, 4/21, 4/23 results. Everybody I talk to, every report that I can include, right on down the line. So if I have to go back and reference something, I can do it as quickly as possible. The more input that you can provide to something like this, the more valuable it is for you moving forward. And the last thing, this was already done. The thyroid FNA has been done. I'm just waiting on the results of that. The Fred Hutch appointment has been done and scheduled for May 13th. As you can see, a lot of tests have been done. We've got a lot of results in a fairly short period of time. This all started off in the first week of April. It's now only the first week in May, and we've got a lot of traction behind us. And time is our enemy in something like this, and I certainly know that. So my goal is to focus very tightly on this, get, as I say, these tests overlapping each other, and move things ahead as quickly as possible, to not settle for next month or the month after or whenever for appointments, but to try and get them to recognize that this is urgent or can be urgent, life-threatening. Please move you to the front of the line. This fine needle analysis that I just got in the throat, that was not scheduled until May 11th. I asked them, as I do with every appointment, to please put me on the wait list, the on-call list. I want to know if another appointment opens. I don't care what I've got going on in my life. I'm dropping it, I'm coming there, and I'll get that test done. And that has helped advance the process a couple of times, as it did recently with the FNA. Thanks for watching. Thanks for caring. And if you have any comments, leave them below. I'd love to see them. Bye-bye.